All right, thank you for joining us. We're less than 2 minutes away from starting our first Insights live session, in which we're going to be sharing some of the insights recently collected through the Geneva Learning Foundation's immunization platform and through partnerships as well. We'll be starting in just under 1 minute, 30 seconds. We've got some really interesting stories, analysis, insights from 3 different sources. One is on gender, and we're going to start there. Second is on the ongoing peer inter-country exchanges being organized by scholar alumni of the Geneva Learning Foundation's programs, and the most recent inter-country exchange took place on 25th of September between the Democratic Republic of Congo and Cameroon, and we'll be hearing what actually both teams gained from that. And then third, we're going to be sharing a few of the insights from the last Teach to Reach Connect event that brought together over 4,000 immunization practitioners, majority subnational from all over the world, who shared their experience together. So see you in 40 seconds or so. Warm welcome to you from Geneva, Switzerland. I'm Rida Sadki from the Geneva Learning Foundation, here with Charlotte Mbuh. Charlotte, how are you this afternoon? I know you're busy.
Hi, Rida. Hi, everyone. I'm fine, thank you. And it's a pleasure for me to be here today.
All right, wonderful. I just want to greet a couple of the people that are here with us online. Let's see. Violette Mideva is connected from Kenya. Welcome to you, following on Facebook. And then we've got Bajos Ndamwenge connecting from DRC. We're going to be talking about the COVID-19 vaccine introduction in the DRC and the exchange with Cameroon as well. And then we have one of our most loyal listeners and a remarkable leader in the scholar community, Amal El-Tahir, connecting from the Kingdom of Saudi Arabia. So let's get started. We have a lot of things we'd like to discuss. With me in the room are a number of guests. Charlotte, could I ask you to introduce them briefly, just their name and what they're doing here?
Okay, thank you very much, Reda. I first of all want to say welcome to all of our guests that are with us today. I want to say hello to Dr. Mita Vashi, that's joining us from India. We also have Dr. Tiella Mbuh, that's joining us from Monrovia in Liberia. And we have Jean Monroe, that's joining us from Gavi, as well as Ian Steed, that is a member of the TGLF Insights team.
All right, wonderful. And before, we're of course going to hear them introduce themselves as we go along, but just to explain to you what this is, at the Geneva Learning Foundation, we've realized that through our programs, especially our immunization program, we're constantly receiving, collecting, hearing remarkable stories, primarily from subnational immunization staff, and we've decided that it was our responsibility to actually share back some of those insights, some of those stories with, first of all, the people who originated them, and also to share them with global and regional partners. We do believe, as you see here on the Insights landing page, that we do need fresh insights to support those like our listeners who are leading change in districts, health facilities, and communities. This is where I want to introduce Ian Steed.
Reda?
Yes?
If I could just say something, there is a guest that just joined that I didn't get to introduce. That is Dr. Calvin Tonga. He's the leader of the Cameroon Scholar Group. That's members of the COVID-19 Peer Hub from Cameroon.
And of course, we're going to introduce Calvin. Before we do that, and thank you for joining us, Ian Steed, together with Charlotte, has been working on these insights. Ian, would you like to say a word just to introduce yourself before we dive into the topic of gender norms, roles, behaviors, and relations?
Thank you very much, Rada, and it's great to see people on this panel this afternoon. I'm Ian Steed. I'm based in Cambridge in the UK, and thoroughly enjoying the opportunity to read so many exciting stories from around the world.
All right, thank you very much indeed, Ian. Now, time to introduce Jean Monroe. She is, I believe, a gender and immunization specialist at Gavi. She'll correct me if that is not the exact attribution. Jean, a warm welcome. Please tell us what you do at Gavi, and then I have a first question for you.
Okay, great. Thanks, Freda, and a pleasure to be with you all this afternoon. My name is Jean Monroe, and I'm the Senior Manager for Gender. And indeed, I support countries to include gender in their applications to Gavi. And one of the big issues that we look at is identifying what types of gender barriers inhibit healthcare workers from the ability to deliver the vaccines, from adolescents to accessing the vaccines, and to caregivers, both male and female, from accessing the vaccines for their children. So these insights that we'll talk about later today are really useful just to hear what's actually happening on the ground in terms of how gender norms impact our vaccination programs.
Wonderful.
Thank you.
Thank you, Jean. And so we're going to be talking about gender norms, roles, behaviors, and in fact, what's the source with the basis for our discussion? Well, during the WHO Scholar Immunization Agenda 2030 Level 1 course, that's quite a lot of words put together, but focus on IA 2030, every participant was challenged to develop a gender story analyzing gender norms, roles, behaviors, and relations. And in fact, 571 participants, learners, submitted such stories. We shared, Jean, 3 of them with you. And you found them to be useful, to contain useful insights. You said they were absolute treasure to hear these very real stories and experiences, and that the caregivers and health workers' needs come through, as does the reflections of the storyteller. What surprised you? Was there anything surprised you about the 3 stories we shared with you?
One of the stories was about the difference between male-run health facilities and female-run health facilities. And there was an assumption and a fear that women were not accessing the male-run healthcare facilities for fear of violence, either on the way to the healthcare facility or violence perpetrated by healthcare workers at the facility. So that was an interesting insight. And we've heard this across countries. But then they also found that one of the barriers that was faced in the female healthcare facilities was that the women running the facility also had many other responsibilities in the home. So often they didn't open up the facility and people couldn't access it because the women were responsible for other work. They weren't paid enough, or they weren't paid on time, so they had to run their own businesses. And this impacted directly on their ability to provide professional services.
All right, thank you, Jean. Let's dive in. This is the second of the 3 stories that we shared, and so Dr. Tiella Mbuh is with us. Thank you for joining us. And at the time, you were working on immunization and health system strengthening as a technical officer, working with WHO in Monrovia City in Liberia. So this was round 1 of the polio campaign in 2019 in Liberia, and you were supervising in Monrovia. The team called to say that there's a lady of the Muslim faith who had an issue. Can you tell us what the issue was? And can you tell us what happened and how it turned out? And I'm asking you to unmute. So, yes, please go ahead. And a warm welcome to you.
Okay. Good afternoon from Monrovia. And my name is Dr. Tiella Mbuh, and I'm very happy to be sharing my story with all of you wonderful people today. As you rightly say, yes, we got a call whilst I was supervising an area in Monrovia during the 2019 campaign. And the issue was a lady of the Muslim faith at home with 3 children under 5. And the team got at her house to do the vaccination, but they couldn't because her husband wasn't at home and she wasn't close with the authority to make the decision of whether the children should take the vaccine or not. So that was it. They called, they got at the house. They couldn't vaccinate the children because the husband wasn't at home and the mother couldn't make the decision of whether the children should take the vaccine or not because that's not her decision to make. So we got there, politely spoke to her. She was a very polite lady. She welcomed us. To note that I got there on the scene along with the national supervisor, who was a male. She welcomed us, but she didn't allow us to enter the house. So basically, we were outside, we spoke. She told us exactly what she told the team members, that yes, she had 3 children under 5 who had previously taken the vaccine, but the fact that her husband wasn't at home, she could not allow the team members to vaccinate the child. So our intervention after getting that information was to request her husband's number, which she gladly did. And we waited for him a little bit to see if he was going to come home. The team revisited the house, but unfortunately he didn't get there that day. So we called him and spoke to him, and he was very receptive. So the next day the team revisited the house and vaccinated the children. So yeah.
Thank you, Dr. Tiella. So your takeaway from this story was, you said one way to address the situation is to recruit immunization teams from all areas or religions. In this case, your belief was that if one of the team members had been from the Muslim faith, persuasion of a mother from the onset would have been easier. Jean Monroe, you work on gender in immunization. You had another reflection about potentially another takeaway. And then I also want to warmly welcome Michaela Manna from WHO, who's also joined us, and we'll be turning to you, Michaela, next. Jean, would love to hear from you on this, having heard this story. What are your thoughts?
Yeah, we've heard this quite a bit, that men have the decision-making power in the home, in certain cultures and certain faiths. And what we've heard from other countries is that they engage men specifically. So they'll hold special men's groups, or the leaders will meet with men outside the mosque and discuss the importance of immunization, and then even bring immunization like a vaccination center to the mosque, and men can bring their own children. So this empowers men to become more active as a parent. It addresses this difference in decision making. But I like what Dr. Tiella did as well. Ultimately, we just really want to get the children vaccinated, and for both parents to be involved in the vaccination.
Thank you. Now, I'd like to turn to Michaela. Michaela, we of course, many of our listeners know you from the Immunization Agenda, the WHO Scholar course on the topic. We've really appreciated your contributions to Lightning Chats. Now, you had a reflection where you said immunization campaigns need to take into account the different distribution of power in household decision-making and how gender inequality can affect women's agency, ability to decide for their children. Men's involvement in care also needs to be strengthened. If you had been there with Dr. Tiella and she had asked you for advice, what would you have said to her? And if you're able to turn your webcam, that'd be wonderful. But
hi everyone. It looks like my camera is a bit weird. I don't know. I see myself kind of black and white and twisted. I don't know what is happening with my camera. Sorry. Anyway, it's glad to be here. Thanks, Reda, and hi everyone. No, I mean, I actually had the same reflection that Jean had, and this is really another further demonstration on how we need to involve father. I think what Dr. Tiella did was exactly what I would have done, and it also shows us that, I mean, we don't need to I think to implement complicated, solutions. Sometimes it's like the solution is simple. We just have to change the way we implement campaigns and just, amplify our the spectrum and involve fathers and as Jean rightly pointed out, empower them and involve them in the decision of vaccinating their children, because this is a demonstration that the father were not opposing to the vaccination of their child. It's just that the mother did not just have the permission, but it looked like it was an easy solution. So that's really a demonstration that we just need to involve them. Thanks for sharing this interesting story.
So Michaela, if you had been sitting knee to knee next side by side with Dr. Tiella in Monrovia, what would be the first piece? What would be and she asks you for advice. What would you say? What should be an action that she should consider, or something to think about?
Well, I think that really, like in the planning of the immunization campaign, to consider the role of fathers. And so also, as Jean said, there are examples of on how we can involve fathers, not just communicate directly to the mothers, but also remember that the fathers are there. So how can we involve them? It also depends on the context. There are also examples of for instance, men being involved in barbershops, or there are experience from NGO that involved fathers in not specifically maybe immunization campaign, but it can apply also to immunization campaign. So really think about their involvement when you are delivering the immunization campaign.
Thank you, Michaela. All right, we're talking about gender norms, roles, behaviors, and relations in the access and delivery of immunization services. But that is not all that we're going to talk about today, because we're also pleased to announce the new podcast from the Geneva Learning Foundation. So go to learning.foundation/podcast. You'll find live streams like this and a lot of other content, whether it's testimonials from people in the field, from national and subnational immunization staff, whether it's technical expertise and advice and dialogue with global experts. If you're here for the first time, welcome to the family. You're part of a platform of immunization professionals. Today we have 38,264 immunization professionals active on the platform. It is not only about what we send you, what we share with you, it's also about what you share with each other. Now, we're also going to be talking about the follow-up to the peer sharing of experience between alumni of TGLF, so immunization program from the Democratic Republic of Congo and Cameroon. We have Calvin Tonga from the Cameroon National EPI team who's with us. And then there's a series of inter-country exchanges. You can see the dates for those that have already happened up on the screen here, running since March, and really propelled by the need for people in countries to learn from people in other countries. So we'll be talking about that as well. And last but not least, we're going to be sharing with you some of the key insights from Teach to Reach Connect. This is our quarterly networking event, and you can see here one of the takeaways, how one participant expressed what they gained from this last event. Now back to talking about gender norms in relation to delivery of immunization services. We have a second story and we have the pleasure of welcoming Dr. Mita Deval-Vashi, surveillance officer at the WHO country office in India. Now, she's involved in monitoring routine immunization and capacity building of government counterparts in Mumbai. Dr. Vashi, a warm welcome to you. You should be able to unmute. Now, thank you. You visited a construction site in the Lower Parel area of Mumbai in 2014. So this was a while ago. It's pre-COVID, but we're very interested in hearing your story. What happened that stood out, that 7 years later you remembered it in the context of the WHO Scholar Immunization Agenda 2030 course, and that you shared as a story focused on gender barriers? Please tell us.
Thank you very much. Actually, there are a lot of gender-related episodes that we see during our field work in immunization. But this one I remember very, because it touched my heart. When I went to monitor a construction site, which was a fully functional construction site in a city of Mumbai, and it had a lot of, hutments at the basement where all the laborers stay. So when I went to monitor there was a house in which one 4-year-old girl was there. She was washing clothes, and with her there was her little brother, 2.5 years old, and he was just sitting there. And when I inquired outside, the neighborhood lady came and she said that I am looking after them because both the parents are manual laborers and they are on the 9th and the 12th floor of the building. They're working now. So I insisted on seeing the routine immunization card and the boy's card, that is the 2 years plus child's card was there, and he was fully vaccinated for his age. But the daughter was 4-year-old. Her card was not there. So I then called the mother and the father. And mother said, we have given only one injection to my daughter. Though the session was conducted few days before in the same construction site, but she did not vaccinate the daughter because her reason was, if I vaccinate my daughter, who will take care of my little son, who will do the household chores, and then I'll have to take leave and I'll lose my daily wages. So priority was not given to vaccination, and she was ignored. The elder daughter was ignored. Then I convinced her. I spoke to her about all the vaccine preventable diseases that we see, about starting from polio, smallpox, and then diphtheria, pertussis, everything, and how deadly they are and why they should vaccinate. And by vaccinating now, they will have a healthy kids, and they may not need hospitalization. So you are preventing disease. Everything I explained to her, and then the father, she got convinced that I will vaccinate my daughter. But even at and she gave this the second dose. A month later when there was a camp in the session site. But still I was doubtful because they are the migrants. They are here in a construction site for a few months, and then they go to another city or probably other construction site. So even at the end of my day, I was a little worried. Though on my insistence, she took it, but will she continue or will she complete the schedule for the kid was my worry. So that's it. That is what I shared in the assignment.
Thank you, Dr. Mita. And so your takeaway, you said, being a woman, you could convince the mother properly, giving several examples, explaining different diseases, starting what she already knew. And the husband, too, was convinced to immunize their daughter. But you felt bad, you said, because even if they immunize once because you're insisting, would they continue to do the same in the future when they go to a different city or site or another construction site? Jean Monroe, you work on gender at Gavi, the Vaccine Alliance. Could you tell us how does a story? How do you reflect on a story like that? And again, if you were there in 2014 on the construction site, side by side with your colleague, what would you share? How would you follow up? What would you suggest? What would you advise?
Well, Dr. Mita, I really enjoyed your story, and it just showed me how multidimensional your role is. You're really not just about the medicine, about the health, about the vaccine. It's the social aspect in your role that is actually so key. And I think sometimes we forget that really, we just see you as somebody coming with a needle, but really it's the interaction, the discussions that you have. And I really enjoyed your reflection on, what's going to happen next time. And I think it's those reflections that are so useful for programming, because it's your thoughts are about how we can change the way we do immunization program, or from a Gavi perspective, how we can support you to make sustainable changes. My one question about that case was, the mother was concerned that she would lose out on her wages because she would have to stay home and watch both children if they had a fever the next day. So what's an approach to overcome that aspect? Are there any things that you've seen in your practice where, that day after, where the children might come up with a fever and might need more extra care? How can we address that when we know both mother and father need to go back to the workforce?
Ma'am, it's very, very difficult actually. When we go to sites and we meet them, the supervisors also, we tell them that at least for a day after vaccination, if mother can be given us some lesser work or something. But ma'am, it's very, very difficult because the mother says that they will pay us less if we do less work. So it is a little complicated to have any kind of, the only thing is we can just inform them the importance of vaccination and how it is going to be helpful for their future. So I could not do much, to help her with that.
Yeah.
Thank you both. You are listening to the first Insights Live. This is something new that we're trying together with partners and friends who've accepted to join us for this first kind of a pilot issue, seeing what kind of, if we can together invent a new kind of dialogue across geographies, across levels of the health system. Chizoba Wonodi, one of the reviewers for these stories on gender, and one of the reviewers for the Geneva Learning Foundation's Insights, had this to say: these are stories we hear in the field and find very insightful, but they never make it to a global audience to inform and inspire immunization leaders who work at higher levels. And this is precisely why we at the Geneva Learning Foundation are hoping to work with partners like Jean, like Michaela from WHO, and with people in the Scholar Network who have stories to share. We have a lot more coming. First on the exchange between DRC and Cameroon, and then about Teach to Reach Connect and sort of key insights gained by participants. Over 4,000 people connected for this event on 10th December. And key insights, you'll be hearing about vaccine inequity, about innovation, and about Immunization Agenda 2030. So stay with us. Don't go anywhere. And we'll be right back. Thank you very much indeed, Jean and Michaela. You're welcome. As we discuss these other issues, please do stay if you can. And a warm welcome again to Calvin Tonga. And we're going to be talking now with Charlotte Mbuh and Ian Steed about the next in this next segment. All right, this is where I do want to turn to Charlotte Mbuh. Charlotte, you facilitated this remarkable meeting between between two teams of alumni from the Geneva Learning Foundation's immunization program. You can see up on the screen, I've got a screenshot. It's not that, this is not a message that Valerie just sent. I do want to, by the way, acknowledge Amel El-Tahir and Amadou Yakubu, who shared really interesting comments on Facebook and YouTube, respectively. We'll be sharing those with Jean and Michaela. We unfortunately, really just only because of the time constraint, we haven't been able to address those. So, Charlotte, I have 3 questions for you about this sharing of experience that took place on the 25th of September, and then I have 2 questions for Calvin Tonga. Let's start with you, Charlotte. So, this was this meeting took place on the 25th of September. Who responded to the call to share experience about COVID-19 vaccine introduction?
Okay, thank you very much, Reda. And I first of all want to thank the team leaders of the 2 countries, that is Democratic Republic of Congo and Cameroon, for inviting me to facilitate the meeting. So 955 immunization professionals from the 2 countries that are part of the COVID-19 Peer Hub and beyond were registered for this event, and they were able to join with the support of their national EPI authorities.
Okay, wonderful. And so what was actually shared, I believe this meeting was over 2 hours and 20 minutes. What was shared?
Yeah, so the DRC country group wanted to hear the Cameroonian experience of the rollout of COVID-19 vaccines. So the Cameroon country group shared their experience of the COVID-19 vaccine rollout around certain key thematic areas like communication for development, AFI surveillance, data management, amongst others. And the participants from DRC were actually listening attentively and asking questions for clarification around everything that was presented by their Cameroonian peers.
All right. And so what is next for the DRC and Cameroon country teams?
So, like you said earlier, the event that was scheduled for 2 hours took almost 2 hours, 30 minutes, and there were over 50 questions that were asked by colleagues from GRC. And so we are looking at having a second part of this series. That's Saturday, 2nd of October, 2021, during which the DRC country team will also share their experience of the COVID-19 vaccine rollout. And the Cameroonian scholars will be able to provide answers to any pending questions that were left unanswered during the first part of this experience sharing event.
All right. Thank you, Charlotte and Mbuh, for this summary. Now I'm going to turn to and welcome warmly Calvin Tonga, who's a longtime scholar. He works in the National EPI team, the expanded program for immunization in Cameroon. Welcome. Calvin, how are you doing this afternoon? Thank you for taking time out of a busy National EPI manager schedule. How are you doing?
I'm doing great, Reda. Thank you for receiving me on this program today. It's a pleasure.
All right. Thank you for joining us. Let's see. We have two questions for you. First of all, before we even talk about the exchange, you know that the concern is over how quickly the COVID-19 vaccine introduction is going in order to cover the most vulnerable and then ultimately everyone who needs to be protected from COVID-19. So in the National EPI team, if we ask the National EPI manager, are you satisfied with the rate, the speed at which the COVID-19 vaccine introduction is going?
Obviously, no, Reda. The target that was set by the country is still to be met, and in the field, we've been facing some challenges with vaccine uptake. However, we're really satisfied with the efforts that were made by the government to secure vaccines for the country, the speed at which the vaccines were deployed all over the country, and a strategy was thought to make the vaccine available to all those who were willing to get vaccinated. So no matter the place where you found in the country now, if you need to get vaccinated, you want to get vaccinated against COVID-19, you can find a vaccination center and receive your shots. The big challenge now is demand generation. Many people have, the beginning was very slow. People wanted to understand, and vaccine was introduced in a context that was characterized by rumors and many other adverse messages against vaccine. So that was a challenge for the National Immunization Program. Immediately we worked on that. We had a crisis communication plan, which is being implemented, and so far we see very interesting progress being made. We see leaders mobilizing their communities to get vaccinated, and we also see the trend in immunization of health personnel that is taking a very interesting shape too.
Thank you, Calvin. And so before I turn to Ian Steed, who has been following these inter-country exchanges for his question, you have been quite motivated, and so have, I believe Charlotte said there were 955 immunization professionals from DRC and Cameroon who registered for this inter-country exchange. What is for you the value of sharing with your peers from across the border with the Democratic Republic of Congo? And what do you keep? What do you take away from such an exchange?
Yes, I think it's very important for us to share with our peers because it's an opportunity for us to learn, but also to make a stop and look at what we've done to find out what worked well and what did not. So it's an opportunity for us as a team to assess what we've done and also share our experience because we think this can help others to improve on their performance or to avoid getting in some trouble we may have faced in the course of the intervention. But for us also, the discussions that we had with the Congolese team gave us some insight on how they perceive the various aspects of the intervention and also some suggestions. I think that many suggestions were made on how we can get our performances improved on what could be done concerning the supply chain, the communication aspect of it, so that we improve on the performances that we've recorded so far.
Thank you, Calvin. I want to turn now to Ian Steed. So Ian Steed has been following the inter-country exchanges and was not able to attend this particular one. So I'm wondering, Ian, what would be your question to Calvin Tonga? What seems like to you like the most important thing to ask and to understand about these inter-country exchanges?
Thank you, Rada, and thank you, Calvin, for being with us today. I appreciate the time. And you've spoken about the value of these exchanges. And I wonder, what would you say to a member of your team, maybe working at a district or a health facility level, who says, this sounds great, but I don't have the time for this. I've got 1,000,001 things to do as part of my day job. How would you encourage them to take time to speak to their peers, to learn from them?
This is also part of the supportive supervisions that we do, because not only we carry out the supportive supervision, but we train them as supervisors also, even within their health facilities. And one aspect of this is also learning from peers. That is, you have something to give, that is true, but you also have something you can learn from others. From what they do, they surely have tricks and some interesting approaches to the interventions they are carrying out, and you can learn from them for yourself, but also to share with other people. So getting in touch with your collaborators, with your peers is also always something that is interesting, is enriching, and it can also help you share good practices to others as in the intervention.
Wonderful. Thank you so much, Ian Steed. Thank you, Calvin Tonga. We're talking here. This is the first Insights Live. So basically, what was supposed to be a 15-20-minute live stream, but we have so much to share. Singular insights by and for the people who make global health is what we are trying to share here. This is something new. We're not, we're still exploring and trying to figure out how to make it work, but we do know that we believe that we do need new kinds of insights as a global community. We recognize the significance of local action to achieve the global goals, but we need fresh insights to support those leading change and a new kind of dialogue with global experts and all stakeholders from all levels of the system. Now, we're going to talk about Teach to Reach Connect Insights. So for those who do not know, this is our networking event. It is now a quarterly event building, seeing how the extent to which immunization professionals from all over the world have taken up the call to get to know each other better, network at a critical time for immunization. So in the last edition on 10th of September, we had 4,454 immunization professionals who registered in order to participate. We know many of you were disappointed because of connectivity issues and technical challenges, and some of you were in the field, but nevertheless, we know that you were there in spirit. And you can see here the actual numbers. Nigeria and DRC were the two countries with the greatest number of participants, but you can see many, many countries, including some that only had one participant in Teach to Reach. So now, what we want to share today is a few of the insights. We've prepared a complete, a really comprehensive slide deck, sharing really the key takeaways from Teach to Reach Connect, and we'll share that with any partner or anybody who's really interested in seeing what these insights are about. But I want to start here with this quote that from a participant who summed up the value of networking. Charlotte, are you available to do a quick reading of this first quote?
Yes, Reda, with pleasure. I had the privilege to interact with very highly qualified, internationally recognized health professionals. It's like an opportunity to dine with the creme de la creme of global health.
All right, we've got a little bit, creme de la creme is one way to put it. And certainly there's people from everywhere who are together, and you get one-to-one meetings with them and get that experience of being able to directly engage. And I heard similarly from folks working at the global level how much they learned by interacting, by connecting with the creme de la creme of national and subnational immunization staff. Value of networking should be obvious, but we find that Teach to Reach Connect participants have a really remarkable way of summing it up. Networking brings learning to my doorstep. I would not have acquired this without this innovative learning platform. Now, the question is, of course, fine, sure, people can enjoy networking. Does it actually make a difference? Hence, this quote is something that Charlotte and Mbuh, who actually put this comprehensive slide deck together, pulled out and identified. This is somebody who works in a rural area and has no connection to outside experts. And so it turns out that for this person, in the face of many, many questions from the community, after Teach to Reach Connect, she says, I have evidence to convince any resistant people. This event was amazing to me. This is a kind of eureka moment. This is the kind of realization that we get that we've consistently seen in Teach to Reach. And you can see here that on the average, the people who actually make it to the networking spend almost 2 hours networking, meeting with each other, discussing, exploring key themes. We're going to share what they were in this on the 10th of September. Now, furthermore, this is very much about interpersonal communication. So you push a button and you're connected with an immunization staff from somewhere else in the world. But we still want to know what people do with that, what people take away. And so we were amazed to see that over 1,000 participants responded to the post-event questionnaire, and 364 respondents didn't just check the boxes, but actually shared, in some cases, very detailed, rich stories on the three themes. So that's 364 people who shared stories around three key themes. The first one was leadership for Immunization Agenda. And Charlotte is going to sum up and read this first quote from one of the Teach to Reach Connect participants.
Effective immunization leadership and teamwork are required for successful immunization programs. Every immunization leader must be effective in leadership and be a good team player.
All right. And then we have the next one. So initially we were struggling with supplies, coverage, and somewhat vaccine hesitancy. Then we applied polio eradication and routine immunization principles in our COVID-19 vaccination campaign, and we got huge success. Now imagine if in the context of meeting with peers, people like yourself who are facing many of the same challenges, even if where they work could be completely different. Hearing a story like this and seeing the possibility of actually achieving, being successful with COVID-19 vaccination. Of course, it's always more complicated than that, but those exchanges are of huge value, especially when they're combined with global and other kinds of and country expertise. Now, Charlotte, what is this one about?
Okay, I talked about low coverage in my area and was happy to learn how coverage issues are being addressed in other parts of the world. And one more thing is that to improve the coverage, we need to work on both aspects, that is supply and demand.
Now, we don't know, of course, the context of these participants. There's lots of, they raise these comments or these quotes raise almost as many questions as, the information, the answers they provide. But they're fascinating insights from participants. What did you gain? We asked, and these are the kinds of responses that we got. Now, the second topic, which was the theme of the second networking session, is COVID-19 vaccine equity. Charlotte, could you tell us what is vaccine equity exactly?
Thank you, Reda. Vaccine equity is it's about making high quality vaccines accessible to all people that need it everywhere at the same time. And talking about that, I have in mind mostly the target populations that we have in mind. I have in mind also those that are living in hard to reach areas or security compromised areas, looking for ways and strategies to ensure that all of these populations are reached. That is, every last child, every last person in need of vaccines gets them. And within the context of the COVID-19 vaccine rollout, we know that the normal target that we usually have for vaccination services changes slightly because we are looking at healthcare professionals and adults that are becoming the target for vaccination. Thank you, Reda.
Now, this is out of order, but it's super interesting. It's actually Amel Elta here referring back to the discussions and the stories we heard about gender, but also about campaigns, who says we need to change the way we conduct campaigns. In Sudan, the time of polio during campaigns, we used to just put a song about vaccination in all supervisors' car. Once children hear that, everyone will come out. And also, Amel welcomed the polio team. She may have known Michela, the previous speaker. Now, what's interesting, and we love this, is that Mary Adomako, Mary, please do tell us what city and country you're connecting from. We know Amel is in the Kingdom of Saudi Arabia. Mary says, good point on the campaign strategy with the use of songs relating to immunization. And we're hoping that in the context of this Insights work and what we're calling Insights Live. So this live stream, this live bulletin, sharing experiences, stories, that you'll also speak back to us. Ask, not only say hello or ask questions, but also share your stories as well. Now, to get back to the networking session 2 on vaccine equity, Charlotte defined vaccine equity for us. And here is the quote: we must always simultaneously work out solutions towards saving the lives of both immunization workers and that of the eligible receivers of immunization. Now, networking session 3 was on innovation in immunization. And here we have probably the longest quote, and it may be challenged in a number of ways. It may be a bit provocative. It may break with conventions or the way we think about a number of issues, but this is quite a long quote. We struggled to sort of simplify it. Charlotte, can you tell me what this person is actually proposing?
Okay, so Reda, this person is kind of like bringing out an idea where public areas could be scouted. That's areas where people congregate and use the platforms for immunization and catch-up. So he says, although logistics will need to be carefully planned, burials, weddings, churches, and other public forums could be used to give vaccines, including COVID-19. For example, he was thinking that if WHO or other partners taking proposals from private clinics or health-related agencies who are willing to advocate and work in collaboration to ensure that their catchment areas are getting immunized.
All right. So, I'm struggling to imagine if a family is burying one of their members or in the context of a wedding and vaccination taking place in that context. But I think the point of, and the challenge with this session on innovation in immunization was to think outside the box and at least consider even the ideas that don't seem realistic or that, that Seems like they would have no chance to fly, but who knows? The one thing that's certain is if we keep doing the same old things, we'll get the same old results. I'd like to turn to Calvin Tonga. I don't know if you're still with us. This certainly wasn't planned to ask you about this, but you're in the national EPI team in Cameroon. If somebody comes to you with an idea like this, what do you do? I mean, and you may not be able to answer us, but maybe we'll follow up with you after this session. Calvin, yes.
In fact, we are up from peers from the field. Yeah, thank you, Reda. I just wanted to say that we are open to ideas from all over the world and also from our peers in the field. And as a fact, we've already received many ideas from the field that are being implemented. We also have the opportunity to see how colleagues in the field shape the strategies that we communicate to them, to their context, and how they adapt it so well that we can transpose them in other settings. So we are really open to new ideas, to new strategies or approaches, the final aim being to reach the last child.
All right. Okay, thank you, Calvin. And so, what would be your initial response to somebody who says, well, can we do vaccinations when a family is burying one of their own, or during a wedding, or at a church?
This will be, I didn't get your question very well. So can you come again, please?
So this person is actually suggesting that, for example, during burials or during a wedding, that vaccinations take place during those times.
It really depends on the context. For example, we know with the COVID context, if we are talking of COVID vaccine, this is possible as long as you discuss with the family, and it gives them the opportunity also to make sure that those who take part to the ceremonies are vaccinated. So some sort of contributing in preventing the risk of propagating the disease. I think this may work, but in other contexts also it might be difficult because people are mourning their beloved person. So it all will depend on the context, and also on the discussion that you have with those who are in charge of organizing the ceremonies, if they accept that or if they refuse.
So we're talking with Calvin Tonga from the National EPI team in Cameroon. It certainly sounds like your team is open to innovation. We're sharing a few of the insights. There's a comprehensive slide deck developed by Charlotte Mbuh about this unique event that brought together 4,454 immunization professionals who registered to participate. And I want to go now to some of our listeners. So let's see. First of all is Akhtar Mohammed Isarakai, who says we need to get support from the community for vaccination, and vaccine equity is important, which should be done by government to reach vaccines to all people of the country. Vaccine distribution should be based on targets. The COVID-19 vaccine campaign cannot implement with polio because polio volunteers have very less knowledge. That is Akhtar Mohammed's opinion. We'd like to know more how you form this opinion, certainly, but thank you for sharing. Amel says one more interesting story in a place in Saudi Arabia during the wedding. They make that to allow only vaccinated people to participate and attend. So in Saudi Arabia, vaccination status is digital in everyone's phone. And Akhtar Mohammed Sarakai has a question: how can we increase awareness about COVID-19 vaccines if we don't have much HFs in health facilities and health workers? So this is the kind of question that, Akhtar, I'd like to invite you to join Teach to Reach. The next one is on the 10th of December, and you share with us. Now, we have one last one that is in French, so I'm going to very quickly translate it. A surprise to learn from my peers how successful they had been in vaccination during campaigns. From now on, I will be motivated and committed to innovate with communication strategies based on the engagement with local authorities in order to successfully succeed with vaccination efforts. So this is this is it for this first Insights Live Bulletin. It's the first time we're trying something like this. We had 3 themes and I believe at least 8 guests, some from the country or subnational levels and others from the regional and global levels. Wherever you are from, we're convinced that we need new kinds of insights, a new kind of insights as a global community. We recognize the significance of local action, but we need fresh insights to support those of you who are leading change. That's it for this session. Thank you. I want to thank Charlotte and Ian, who prepared a lot of what you heard discussed today, and we look forward to let us know what you think of this kind of a live stream. Is it useful to you? Is it worth listening to? Should we do more? Should we give up? Should we stop? Let us know. Give us your feedback. We are constantly listening and reading your comments. Thank you for those, and wish you well and take care.